Resource Center of Wisconsin. Like Lisa said, I am of WCTC, and kind of from there I got my RADC, it's the equivalent of a SACIT at the time, and started working. I was working in a group home for adolescent boys with drug and alcohol issues, and then went to an outpatient clinic and stayed there for a couple years while I was working on my bachelor's, and transitioned from there to a methadone clinic, where I finished my bachelor's and got my CADC 2 and 3, so that's the equivalent of a CSAC now. I've been with the AIDS Resource Center for January will be my 15th anniversary. So while I was there, I got my clinical supervisor license and then went back to school for my master's, which I finished in 2012, and then got my LPC. Kind of just due to some personal life things, I had 2 kids, and full-time work just wasn't doing it for me anymore, so I tendered my resignation, but the place is part of my heart and soul, so I've stuck around for 2 years now, part-time, just doing clinical supervision and the program coordination stuff. On top of that, I do some independent contracting for mental health clients a few hours a week, and I'm also the clinical director of Fourth Dimension Recovery Center. So I'm here to talk a lot about what ARCW does and harm reduction in general. As I go through, please stop with any questions in real time. The AIDS Resource Center of Wisconsin, which will sometime next week be rebranded with a different name. We have expanded into different locations out of state, and the name, the AIDS Resource Center of Wisconsin, no longer fits. So a little bit about AIDS Resource Center of Wisconsin started as the Milwaukee AIDS Project. In the heart of the HIV epidemic, there were numerous AIDS service organizations around the state and around the country. MAP was one of them. Over time, ARCW came to kind of own all of those AIDS service organizations in the state, and we now have locations in Denver, Colorado, and St. Louis. The AIDS Resource Center is considered an HIV medical home. That means we have a special designation through Medicaid. A number of years ago when Jim Doyle was still governor, he came down to the agency and signed this medical home thing into law, into Medicaid law. It's kind of exciting. The medical home designation means that because we provide all these other ancillary services, we can bill Medicaid at a higher rate. So there's medical services at ARCW, there's dental care, there's a pharmacy on site. The pharmacy also will deliver medications within the city and to the other locations statewide. We have some attorneys on site. Those attorneys specialize in HIV discrimination, disability cases, a lot with housing and employment. We also have case management services. So case management services and ARCW can mean a lot of different things. Medical case managers, so if someone has some really complicated medical concerns, they'll get a medical case manager who can help them navigate all those different systems and make appointments. There are linkage to care case managers. It's a pretty neat job. Those case managers work with people who are maybe newly diagnosed or who have been out of care for a while, and their job is to get them connected with medical care and the other services they need. So they might pick them up at their house and bring them down personally to the doctor, or get them, make appointments for them, take them to other types of appointments. There's also housing case managers who help people get rent assistance, which there's a lot of rental assistance and housing programs for the HIV population through the Ryan White Care Act. That, if you're familiar with Ryan White, the federal package has been renewed every single year since, providing monies for services and medical care to the HIV population. So ARCW has housing services, we manage some rent assistance, and then also have shelter care. We have behavioral health and wellness, and my program is a part of that department. So there's AODA treatment, there's psychotherapy, there's psychiatry, and telehealth. So in some of the greater Wisconsin agencies, a client might meet their psychiatrist via telehealth, so via the computer. There's also a food pantry and prevention services, which I'll get into later, and prep services. We have locations in Milwaukee, Kenosha, Green Bay, Appleton, Wausau, Superior, La Crosse, Eau Claire, Madison, Beloit, and then Rocky Mountain Cares in Denver, and St. Louis Effort for AIDS in St. Louis. So ARCW in general follows a harm reduction philosophy, meaning we meet people where they're at, and our services show that. So I wanted to talk about what harm reduction means a little bit. So what does it look like? Harm reduction can mean street outreach, clean needle exchange, opioid overdose prevention or reversal, Narcan or naloxone, if you're familiar with that, that's what that is. Condom distribution, which can happen at the agency, in the community, at bars. HIV, hepatitis C, and other STI testing, that can also happen remotely or within the agency. Education on safer injection practices. So a prevention staff might meet with someone who's coming in for a needle exchange and educate them a little bit on, you know, your arm looks pretty bad, your veins look like they are getting a little beat up. Well, let's talk about what you can do to make that a little safer and reduce your risk for infection. Harm reduction can also mean things like the bad date sheet or the bad drug sheet. The bad date sheet, if you Google it, if you are interested, it is basically a newsletter that a provider who was working on one of these in Illinois a number of years ago brought the idea up to Wisconsin and started it. Agencies who work with sex workers can provide an anonymous resource to report any behavior or circumstances, situations on the street that might feel unsafe. So they can give this report to a provider who will anonymously send it to this newsletter, and then those providers and other places print out the newsletters and hand them out to people. So it might be like, hey, watch out for this guy in the blue Honda on National. There's also an offshoot of that, which is the bad drug sheet. So it's similar in presentation, but it's about maybe bad batches of drugs, what to look out for, what if a dealer was sketchy in some way, or if something was tainted and you didn't know it. Harm reduction also means the Good Samaritan laws and the HOPE Act that was passed a number of years ago, but it was spearheaded by Representative John Nygren from Marinette County. Is anybody familiar with this?
I've heard about the Good Samaritan.
Okay. So basically it's for overdose protections. There's a medication, like a drug called Narcan, which is used to reverse opioid overdoses. It's very effective, but somebody needs to administer it to someone in overdose. So what the Good Samaritan laws do is protect the person administering the Narcan from any kind of legal charges, unless there's open warrants about something else, then you've got free reign. The hiccup in this is that the person who's overdosing, if they still have drugs on them, they might get a possession charge. In the scheme of things, that's better than dying. But the Good Samaritan laws provide protection for that, and they also protect the administrator from any kind of lawsuits.
Doesn't the Good Samaritan law cover any, like, I don't know what the word I'm looking for, but if someone gets into a car accident and you administer CPR but you accidentally break their ribs, doesn't the Good Samaritan law cover that as well?
Yeah, any life-saving measure.
Yeah, okay.
Yeah. So this was especially added for Narcan, which kind of at the time distributing and administering naloxone on someone who it wasn't prescribed to was a little fishy. Because people were being trained in Narcan, and you had to have a prescription to use it. But it was rarely ever being used on the person who had the prescription for it. So this covered protections from all this. So you could come across somebody laying on the street and you can give them Narcan if you're not even sure what's going on with them and you can't be.
You can't be charged.
Yeah. The HOPE Act legislation also opened up a good deal of money through the state of Wisconsin and allowed Wisconsin to target opioid treatment in rural areas. So up in like Marinette is one, Rhinelander, Minocqua area is another one, and I wanna say Hudson, Hurley, somewhere the northwestern part, Hurley? Yeah, somewhere up there. So those are areas which, access to medication-assisted treatment like Vivitrol, Suboxone, Methadone, it was really difficult because you would have to travel.
High rate up toward Rhinelander and stuff,
Mhm.
those type of drugs.
Yeah, definitely. So they did their research before they made these hubs.
I don't know if this is like off topic, but, you said you're right, you're doing substance abuse stuff like that, yeah. So because, Suboxone and Methadone are very addicting, would it like harm them if they were prescribed instead of, naltrexone? Because you can't get high off that, and it blocks the cravings. Like, would that be, I don't know, like a better choice, or is it just like the only way, if they're that far into their addiction, if methadone and Suboxone would be a better thing, like as far as not getting seizures or something like that, you know what I'm saying?
Yeah, no, all three are viable options, and it depends on each particular person's like addiction profile.
Right.
So there's a lot of reasons a doctor might choose Vivitrol, like Suboxone over Vivitrol. And a lot of it is based on, have you been on Vivitrol before? How many, have you had relapses and multiple detoxifications? How long have you been using and how often? But for many people, just entering recovery, Vivitrol works wonders.
Yeah, I mean, it's kinda scary though, cause if you do use, you'll have to use an excessive amount, and you can die. And I understand how like, that might be an issue with people that are like, in active addiction, you know what I'm saying, and, that answers my question.
Oh, yeah. There's also an injectable form of
Right.
Suboxone
Yep.
called Sublocade. That's just pretty recently being utilized. So it lasts for 30 days, and the benefit of that is it can't be sold on the street. It can't be abused because it's in your body for 30 days. It's
Smart.
Yeah, it's not cheap, but maybe down the road it will be. So medication-assisted treatment is harm reduction. And it's actually one of the best ways to prevent overdose. People on medication-assisted treatment are exponentially less likely to overdose. Harm reduction could also be handing out hygiene kits for sex workers, condoms, deodorant, sanitizer, things like that. Harm reduction can also be supervised injection sites. They're pretty rare in the United States, but they're utilized in Canada. Harm reduction is also services for people pre-treatment. So kind of group centered around what are the barriers to get into treatment, and what can we do about those barriers? It's kind of assessing people's readiness for treatment. And then there's harm reduction treatment, which is what we do at ARCW, and I'll talk about more later, and fentanyl chesting strips are a form of harm reduction.
Do you do any services for like this significant others of people who like have like HIV and stuff? Like, do you help them like navigate like having a partner who has that?
Yes, yeah, it used to be called, what was it called? Positives for Partners, I think. So kind of some behavioral health counseling, for partners and family members. ARCW also does PrEP, so that's, is anybody familiar with that? Seen any of the billboards?
Yeah.
Get prepped up.
Yeah.
Pre-exposure prophylaxis, and that's giving a lower dose HIV medication, typically Truvada, to someone might be in a relationship with someone who's HIV positive, but they're HIV negative. So that gives them protection and dramatically reduces the likelihood of transmission. And that's fully funded, so for right now, anybody can kind of go into ARCW with a partner and get that medication.
Can you repeat what you said, that the, Narcan is
The Narcan, opioid overdose.
opioid overdose?
So overdosing from, any of the opioids, heroin, fentanyl, Vicodin, Percocets.
Can you tell them a little bit more about that fentanyl testing strips and the research that?
Yeah, ARCW's been piloting, we started out in Milwaukee, we've been piloting, handing out fentanyl testing strips with needle exchanges. So, fentanyl is a synthetic opioid. There is a legal medical use for fentanyl when it's made in by a pharmaceutical company, but it's typically only prescribed for chronic pain, basically like chronic, like long-lasting pain, like end-stage cancer. When it's given for that, it's in a patch, a time-release patch form, sometimes in a lollipop, so it's all time-release. The fentanyl that we hear about being responsible for overdoses is typically not that. It's fentanyl that's being made illegally overseas, in clandestine laboratories here too.
Well, it's not only that, there's people out there who are actually sucking the jelly out of the fentanyl patches and getting high off that. Like, that's like extremely bad, I hear.
Yeah, I've talked to people in like the
I know people
healthcare
who have done
industry,
it,
take
I've
them off
watched people do
patients
it,
and,
it's
yeah.
terrible. Terrible.
Find out all type of stuff that, what?
Medical fentanyl is a patch, so it's
Right.
time release, so it sticks on your skin and you keep it on like 24 hours, sometimes longer. And for people who are in need of that chronic pain, it is helpful. But some people will either steal them, people who maybe work in nursing homes and they come across a patient who has one and they'll take it off and they'll like chew it and suck on it and get all the medication out.
Oh my God, I was wondering, cause I used to work at a home, that's one of what they used to be really like on you about their medication and the patches and you gotta sign up for them, so I'm like, what is this, I'm like, I don't know, I am into drugs, so I don't like what they meant at that point.
People just
Yeah.
nasty things.
Will kill you quicker than anything.
I think so, that's what I've heard.
Quicker than heroin.
Yeah, but I got there's a couple of companies that's on the fentanyl patch, and I'm like, we have to count them every day, we people, to the nurse, and
Yeah.
it's a lot you gotta sign in and out for it. I never understood what it was for though.
Yeah. That, the pharmaceutical grade,
So.
legal fentanyl, it's not abused very much. The problem that we hear about on the news all the time is illegal fentanyl. That's like, made by drug dealers, and you don't know what's in it, and they don't monitor the strength.
You know those, all like the reports of like the THC cards and stuff like that in pens, like people are dying from that, that's because people are putting fentanyl in it, and they're overdosing on fentanyl because they think it's taking in THC.
Yeah, and you don't know what it is. So ARCW started trying to save lives because, we've been trying to do that for years. But the fentanyl testing strips are available so you can see what's in whatever drug it is. They had some pretty raw data that the state just took and released, that basically, I don't have all the numbers, but 2/3 of people who responded self-reporting to using these fentanyl strips that ARCW handed out made some sort of behavior change due to the result of that test strip. And those behavior changes ranged from throwing out your drugs, which I think was 7% of responders, to taking the shot more slowly, to calling people to use with you, or to snorting it instead of injecting it. They did something differently. So, that 2/3 is pretty good data showing that like this works, that people are using it to be more safe. Just a little bit about ARCW's prevention testing and needle exchange. In 2017, almost 4,000 tests, and there were 18 positives found. Hepatitis C, in 2,000 tests, there were 139 confirmed positives. 47,000 needle exchanges in 1 year, and 5.5 million syringes distributed through those needle exchanges. The term needle exchange is a little misleading. It's not one-for-one. A person can come in with used needles and give them, surrender them into a biohazard box where they're properly disposed of. But they don't have to bring in 5 needles and get 5 needles. The goal of the needle exchange is to have readily accessible, clean needles for people to use to reduce the transmission of HIV and hepatitis C. And in 2017, almost 6,000 new individuals completed opioid overdose training. So those people were anywhere from active injection drug users to family members to community providers, people in schools, anywhere somebody might overdose. Like gas station employees, because you hear that a lot. A gas station employee finds out that their door's been locked to the bathroom for a while and goes in and there's somebody overdosing in there. So, and overdose really touches almost every aspect of our society right now. Are you familiar with HIV? You want a little basic HIV 101? Okay. I'm not a nurse, so bear with me on this. So HIV is a virus that attacks the immune system, specifically the CD4 T cells. It decreases the number of available T cells and then leaves the body vulnerable to infections. It also replicates within the body, which leads to a viral load. So the virus itself can grow and grow and grow. Antiretroviral treatment is a combination of different medications which can reduce the amount of HIV or the viral load in the blood and other bodily fluids. HIV is the virus that can cause AIDS, acquired immune deficiency syndrome, and that designation is based on the number of T cells in the blood and the number of the viral load. So what the antiretrovirals reduce the replication of the virus. It used to be that once you hit this level of AIDS diagnosis, you stayed that way for life. That's not the case anymore because the medications have really done wonders and can bring that level down to even an undetectable rate.
So now they found the cure basically? The cure being found?
Well, I don't want to say that, but there's no flat out cure, but people are living longer. And I've been there 15 years, and we are now figuring out, like, are the client population is aging. The client population is now like in their 60s. So there's all the other problems with aging, and a lot of these people didn't expect to live that long. So it's pretty amazing. The idea of undetectable means that the viral load has fallen so low that it's basically not there anymore. So the CDC has a campaign called Undetectable Equals Untransmittable. They say that if someone who takes HIV medication as prescribed and can maintain an undetectable viral load, the rule of thumb is for 6 months at least, they have effectively no risk of transmitting HIV to their non-HIV infected sexual partners. All this data is on sexual partners. It's not on like needle sharing, so injection drug users don't fit into this classification. And the maternal transmission rate doesn't fit into this either. So a mother who's HIV positive would still need to take other precautions at birth and after birth. Is there any questions about that?
Yeah, so, like, let's say a person has HIV and they didn't get it from someone else, where else would they get it from?
HIV is transmitted through bodily fluids, so, at birth, it can be transmitted through breast milk, it can be transmitted through sexual contact and blood to blood.
Is it just like a virus that just like is on surfaces or something?
HIV doesn't live on surfaces very long, hepatitis C does. Hepatitis C can live on surfaces for a long time. So,
Can we transmit through saliva too? No, just through blood, okay.
blood or sexual fluids.
Right, I gotcha.
Any other, like, that was just a basic kind of HIV thing. Do you have any other questions? I may or may not be able to answer them. Like I said, I'm not a medical professional. So I want to talk a little bit about the harm reduction philosophy in general. Harm reduction accepts that for better or worse, people are going to use drugs. Drugs are a part of our world, and harm reduction chooses to work to minimize its harmful effects rather than simply ignore or condemn them. Harm reduction understands that drug use is a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe abuse to total abstinence, and acknowledges that some ways of using drugs, or some drugs, are clearly safer than others. Harm reduction recognizes that poverty, race, class, social isolation, past trauma, sex-based discrimination, and other social inequalities affect people's vulnerability to substance use disorder and their capacity to effectively cope with that substance use disorder. And harm reduction doesn't attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drugs. Harm reduction doesn't give people permission to use. Harm reduction accepts that people are gonna use, and the people who use drugs are deserving of services. So I'll just kind of run through a few of these. So in harm reduction, we measure success by improvement in quality of life, not just in abstinence from alcohol or drugs. A client's goals and treatment plan in harm reduction treatment is just that. It's what they want to work on and their timeline for doing it.
This is the AODA?
This is harm reduction in general, but this is what we also use in the AODA treatment. Abstinence is not necessarily the only goal. Any reduction in client-identified harm is seen as progress, and that positive change brings more positive change. When people's lives start to improve, then they typically will make more positive changes. Change is seen as a process, doesn't happen overnight, and there are still supports that can be provided through that process. Harm reduction acknowledges that there are benefits, perceived benefits of using, along with the benefits of changing that behavior. In harm reduction, the client's the source of their solutions to the problems. Encourage safer use and risk reduction practices. It's typically not a confrontational approach, but we don't encourage use. It aligns well with medication-assisted treatment as well as with the full spectrum of prevention. And kind of by that meaning, I've worked with clients in the AOD program who maybe have been referred by to the needle exchange, and if they use again, we'll go back to the needle exchange, maybe get them tested, kind of this back and forth, what are the services that we can offer you, all at the same time. You're interested in HIV surveillance data? So I just have one slide on the 2018 new transmission information, so new HIV diagnoses, and I just pulled out the information on transmission rate of injection drug use, and then male-to-male sexual contact with injection drug use. So this is all self-reported by new diagnoses. In 2018, there were 4 diagnoses with a reported transmission category of only injection drug use, and 8 new diagnoses with a reported transmission category of male-to-male sexual contact and injection drug use. The number of diagnoses attributed to injection drug use alone was lower in 2018 than it was the previous year, where there were 17. So that's a pretty big decrease, 17 to 4. And about the same male-to-male sexual contact and injection drug use. 2017 was 7 and 2018 was 8. So the 2017 rates were high in the injection drug use category. They're almost double the rates of 2014, 2015, and 2016. Probably attributed to like an increase of people using. In 2018 in Wisconsin, the new reports in the injection drug use only category is 2%. If you compare that to the rate outside of Wisconsin, that rate's about 6. So Wisconsin, what we're doing in Wisconsin seems to be working. This is the link to the full HIV surveillance report from 2018 if anybody's interested. Naloxone, Narcan. Are we familiar with this?
So how are you familiar with it?
This is for drugs that's an overdose, right? You say it helps the overdose from opiates, certain drugs.
I watch live TV a lot, honestly,
Me
and
too.
I've seen them like have to shoot somebody with like Narcan because they're overdosing their
You gotta
brain.
go on
Or
right.
something.
They use that all the time, though.
That's what that is. That's what I say in movies, right?
Yeah, that's
You
what I
overdose
see.
and they can take that pin and you gotta hit them in the chest with it.
They use a Narcan.
Well, it's the leg or the butt now. But
Oh, so it's no longer in the chest. You know, in the movies, that's what they show.
yeah.
I never seen it in real life.
They
So
use
it's the
nasal
leg, you say
spray.
it's the leg or the butt?
Mhm.
Wow.
Yeah.
Was it Pulp Fiction when she had got stuck in the chest with it?
That was, I thought, adrenaline, though. I thought that was an adrenaline shot. And
She was overdosed.
yeah.
So I thought that it was at first I thought it was a really cool idea that someone created this for people, but then as time went on, I kind of thought it was in some ways very stupid because it gives people who are addicted to heroin, like, well, they could just bring me back with it. A lot of people think that way.
They use that all the time,
Yeah.
all the time for people that
That's their excuse.
Yeah.
Right.
I guess
Just
it
keep
is a good
using,
thing, but
and
then
I'm just
they
gonna
just-
save me.
Playing with that.
Some kind of give or take on the feeling.
They're banking on somebody to get there.
It's not cheap
People are
either.
Right.
The nasal spray isn't cheap. Yeah. The injectable is pretty reasonable right now.
I believe it.
Our former director of prevention, who is now one of the deputy directors at the state for the Division of Care and Treatment Services, he's been a harm reduction champion for, he was at ARCW for 25 years, so he's been really pioneering a lot of this. He always says a dead addict can't get into treatment. A dead addict can't recover. So, there might be some ideas about there, like, some preconceived notions maybe, but I feel at least that we need to remember that people's lives are just a look at their lives.
But the people are still doing it to themselves. You can only help people who want to be helped, and sometimes they're just, I don't know. I've got strong feelings about
Like
Narcan.
there's like a overdose as many times as you use Narcan, they're still gonna do it all the time. As many times they're gonna use a Narcan, they're still gonna do it.
I mean, I get it, there's just people out there who are trying to help. The same thing
Yeah,
with the
I
methadone
see
clinic.
all.
I know so many people who go to the methadone clinic and still use daily. Like, there's just, right.
I don't know, but my thoughts and feelings on that is that I never know what it is that's gonna take that it's gonna take for somebody to see, that change is possible. So that's not my concern. My concern is like helping them
Right.
to get support during that journey, and like they'll get it, right? People eventually get it. People wanna live better lives. There's a lot of barriers and there's a lot of reasons why they might not be able to do that on our time frame.
There was no.
Like, yeah, I went to the hospital
So naloxone or Narcan's a brand name, is an opioid antagonist. It's approved by the FDA to prevent overdose by opioids such as heroin, morphine, and oxycodone. It blocks the opioid receptor sites and reverses the toxic effects of the overdose. So it's administered when someone is showing signs of opioid overdose, lips blue, unconscious, breathing has slowed. The medication can be given through a nasal spray, intramuscular, so injected straight into the thigh or the butt, or under the skin, or it can be also given intravenously. Typically, that's not what happens.
But can you go back for a second? Can you?
Naloxone is now available without a prescription to anyone who wants it. If you use your insurance, they might want a prescription, and there might be a cost for it. ARCW does continue to provide no cost Narcan.
Just go buy this over the counter, what you saying?
Well, you have to go to the pharmacy, because that's where it is, but you don't need a prescription to get it in Wisconsin anymore.
Is there like an age requirement? Like I know some like even cold medicines you have to be over 18.
I don't believe so. A couple of years ago at a major like opioid treatment providers like national convention, there was a Surgeon General in Maryland who was talking about a push to co-prescribe Narcan with any pain med. So anytime you would get a prescription for Vicodin from your doctor or your dentist or ongoing pain meds, to always offer that prescription for Narcan, because the risk of overdosing through legally prescribed medications is very significant. It's pretty much just as high, because anybody could overdose at any given time. Anytime you mix drugs, it's not 1 + 1 = 2. One day it might be 1 + 1 = 3. The next day it might be, 1 + 1 = 7, and you're dead. So we can't ever just assume that because there's a medication we or somebody that we know have taken regularly, that they have a tolerance and they're really okay. So it works by kind of kicking out the opioid from the opioid receptors. It has a stronger affinity to the receptors than other opioids, so it removes like the heroin and it fills those receptor sites for half hour to 2 hours. Somebody might then overdose again as the Narcan wears off and the opioids that are still floating around in the bloodstream connect with the receptors. So that's why it's if you would ever Narcan somebody, call 911 right away, because you don't know what's gonna happen. There's some videos on how to administer Narcan. The second one is about the intramuscular spray, so it's from the pharmaceutical company, and but you can watch those if you're interested.
I was gonna ask, do they need, because this is the part I don't know, do they need additional medical care after the Narcan's administered?
Typically, so there's, depending on how long the breathing and heart rate have been decreased, there could be some significant problems. From cognitive delays because the brain was deprived of oxygen.
Right.
So somebody should always call 911 if you suspect somebody's overdosing. Administer Narcan and then stay with the person at least until 911 gets there. That's in the physical therapy, occupational therapy world. That's kind of a new subset of clients. Clients are coming in with some cognitive delays from brain damage, essentially from their brain being deprived of oxygen during the overdose.
Is this whole PowerPoint gonna be on, are you gonna put this in?
Okay. If you do choose to watch the first Narcan training video, just be aware that it's a little graphic, shows drug use, it shows an actual overdose. It's from the Chicago Recovery Alliance, who has been huge in the harm reduction, needle exchange movement for years. So it's a little bit difficult to watch. It's what we actually used to train Narcan users on. So it's got a lot of valuable information. ARCW's AODA program, I just want to talk to you a little bit about that. It started in 1997 as an offshoot from the prevention needle exchange. The idea was we're providing all these services, we're providing condoms, we're providing needles, we're talking to people who are coming in about getting into treatment, but we don't have a lot of places to send them. So we started as an outpatient and day treatment program, kind of linking all that. We all used to be in the same building, so it was, you know, here, let's get you some needles. Do you wanna talk to a counselor right now? Are you interested in treatment? So our treatment our program was founded on the harm reduction philosophy, meeting people where they are at, regardless of where they were in their change process. So we were initially in the prevention department until about 7 years ago, and we transitioned to behavioral health and wellness. The AODA program remains the only program at ARCW you can access whether or not you're HIV positive. So because we started out with those outreach clients and needle exchange clients, we've continued to work with the general population. We're licensed through DHS 75 to provide day treatment outpatient, and we have AODA services available in Milwaukee, Green Bay, and Madison. Madison is not up and running right now. We're looking for a counselor there. Oh, sorry.
Can you tell them where you're located?
Oh, yeah, the Milwaukee office is on, it's 820 North Plankinton. So it's on Plankinton between Rock Bottom Brewery and Benihana. So we have Pure Marquette Park on one side.
You say where?
On Plankinton downtown, it's a couple blocks from Grand Avenue, but between Rock Bottom Brewery, Wells Street, and Kilbourne.
So it's not a building that's actually broadcasting that?
No, we don't have our name on our building.
Okay.
The 820 is pretty prominent, but we don't have any signage about what we are until you get inside.
Yeah.
The programming that we have for substance use disorders kind of varies on the whole outpatient day treatment spectrum. So we have a group called Recovery Exploration. It's a weekly 90-minute outpatient group, and it's focused on people in the contemplation stage of change. So people who maybe aren't sure where they're at. You know, how bad is this problematic for me, or isn't it? Do I need treatment? Do I not need treatment? We actually work with a lot of people with driver safety plans, intoxicated drivers, through this program, and kind of help them to decide, is my behavior causing more problems? What sort of changes should I make? We also have outpatient groups, so that frequency and intensity varies according to the client need. Somebody might come to a group once a week for 3.5 hours, or twice a week for 3.5 hours, or a little bit of both. Our day treatment group is 12 hours of group therapy per week plus one individual therapy session. So this falls under Wisconsin's requirements for a day treatment program, and that's 12 or more hours of treatment a week, typically for about 5 weeks. From there, clients will typically drop down to outpatient, so they were coming to group 3 days a week during day treatment. Then they transition down to 2, and they transition down to 1.
Are y'all inside of prisons as well?
No. We also have an aftercare program. So that's a weekly 90-minute outpatient group. Really kind of focused on what now? I'm dealing with life clean and sober, so what do I do now? We also offer individual counseling sessions, and ARCW is starting to provide medication-assisted treatment in the office for some eligible clients. So we are piloting a treatment group based around that. A Green Bay program is a recipient of state injection drug use, treatment and prevention funding. So that program has some eligibility requirements, and that is risk of injection drug use. So that program targets people who are using opioids, crystal meth, crack cocaine in some instances if they're injecting it. They run a 9-hour-a-week intensive outpatient program plus an hour of weekly individual sessions and an outpatient group, so kind of again, maybe it's 3 groups, maybe it's 2 groups, maybe it's 1, and then an aftercare group and individual sessions. And we're working on a pre-treatment group there that's gonna look a little bit different. Honestly, that's what I love about ARCW is we were able to target our services according to the location and the clients that we're working with. So for instance, in Green Bay, we've noticed that sometimes the clients who are using crystal meth struggle to come to group on Monday morning. So we're messing around with the schedule to see if can we maybe start group on a Tuesday, like do a Tuesday, Thursday group to better meet those clients' needs if Monday is a little bit too difficult. In Madison, like I said, we're hiring for the position right now, but we're expecting this to be an intensive outpatient program. Again, our Madison client base might look a little different, so we'll, start looking at what the client's needs and tailor our program accordingly. So, how do we use harm reduction within the treatment setting? The day-to-day groups look the same. Except that people might be at different stages of change. That can work really well, actually. There could be somebody who's struggling with getting like 2 days consecutive clean in group next to somebody who's been clean for a couple months. And they can learn from each other. And the person who's has some clean time can really be back connected with the pain that is active use. People tend to be really supportive of each other no matter where they are, because harm reduction says you're worthy of life and your life is worthy of respect, and you get to make the decision about the changes you want to make. We will give you all the support you need when you need it. Early needle exchange efforts were illegal. So there were, across the country in San Francisco, Chicago, was a big one where these vans giving out needles was illegal. Public opinion and the government opinion has since changed in most states. If anyone remembers a couple of years ago, that HIV outbreak due to injection of a drug called Opana, there were no needle exchanges in that state. There are now. There was an emergency rule to create needle exchanges. Narcan, I kind of talked about how this has changed a lot too with the HOPE legislation. Narcan has been distributed widely. So paramedics, you can basically kind of go to most community centers and people have been trained in Narcan and opioid reversal. People know what this is. It used to be kind of a below the scenes sort of thing. Now it's out there. The Wisconsin HOPE Act and Good Samaritan laws have really led to this public knowledge and acceptance of harm reduction techniques and philosophies. In fact, the DHS 75, which is how the state of Wisconsin licenses treatment providers, they are revising their rules for 2021. And one of the proposed changes, it would require all substance use treatment centers to have naloxone and Narcan on site. It's pretty amazing. And harm reduction during treatment isn't a new thing. Harm reduction-based therapy has been studied immensely. Alan Marlott is the pioneer. He did a lot with harm reduction, harm reduction-based relapse prevention. There's a program on the National Registry for Evidence-Based Practices called BASICS, which is harm reduction used with college-age students. A really good book is called Changing for Good by James Traska and John Norcross. So they're the big, MI stages of change people. I added a couple of slides about MI and the stages of change in general. You guys can kind of look those over unless you have any thoughts or questions about it.
We'll be learning about that in class.
Okay.
Yeah, I have a class with that. Human service interventions.
Why do we use harm reduction during treatment? Because the risk of death is real and it's high. Dead addicts don't recover. Any support towards positive change is therapeutic. Lapses can be processed with honesty within the treatment environment. So sometimes in abstinence-based therapy, clients are referred to a higher level care if they lapse. And that might be justified, but it isn't always. Sometimes if you can process that lapse within the group of your peers that you've been with for a while, with your current treatment providers who you have a relationship with, sometimes that's where change can really come from. Harm reduction treatment also increases internal motivation to change because we can support people as we try to get them services to reduce those barriers. So if it's, I don't have childcare, if it's, I don't have transportation, if it's like, I'm just using it to keep the sick away, and I wanna go to treatment, but I can't keep the sick away. That's what harm reduction can help with. That's all I have. Was there something that we wanted to take a little bit more time on?
Can you go back to the, I just wanna write some stuff down.
Okay.
Can you go back to the ALBA treatment?
Any other questions that you can think of? Because a lot of the knowledge or way we think about treatment is primarily abstinence-based.
Yeah, and harm reduction and abstinence-based treatment are mutually exclusive. They can exist on the same continuum. So.
Because the ultimate goal is to have abstinence, but.
Yeah, it's very rare that somebody comes into harm reduction treatment and is just like, I wanna keep using a little bit for the rest of my life. It doesn't happen. People's goal is abstinence. It's just how do we get there? So maybe it takes years, and that's okay, because life is still getting better. My client case that sums up why harm reduction is so important is a man that I've worked with for probably 12 of my 15 years at ARCW, and he came in using crack cocaine 2, 3, 4 times a week. It's pretty problematic. He didn't have any place to live, he wasn't working, he didn't have any kind of income, and he was engaging in sex work in order to get money for the crack cocaine. So that's what he wanted to stop when he came in, because his viral load was really high, he wasn't healthy, he wasn't taking care of himself. Sex work. So he was prostituting. In his case, he was dressing up as a woman and engaging in sex work, which then later, he got shot once doing it. And he stopped using cocaine because he did that to get money for cocaine, and that almost cost him his life. So there was that revelation, and he then started to really make a lot of changes. He continued to drink every now and again, would cut down, start up again, then he relapsed on cocaine, got shot at again, and then that was it, that was done. After that, he even quit drinking because he made the connection that drinking makes me more likely to want to use cocaine. So this whole process took a number of years, but he's now got an income and a place to live, and he's not putting himself, making choices that put him in danger on a regular basis. So I think about what would have happened to him had he not been in a place that was so understanding and so welcoming, because we stayed with him the whole time. It wasn't like, well, you were out engaging in sex work. It was, I can't believe that happened to you. You must have been so scared. What can we do to help you?
Right.
More and more abstinence-based treatment programs are accepting that harm reduction is out there. Just getting a lot of treatment providers to have Narcan on site is amazing. Typically, when you go into treatment, you sign something saying, I'm not gonna use while I'm in treatment. I'm I'm not gonna use from this day forward. And that can set people up. Because how do you be honest with that if you're afraid of being kicked out? When people who've been working in the field for a while, challenge harm reduction, I would say, like, think about a client, an individual client who made progress bit by bit. Like, you do harm reduction, you just don't call it that, right? Like, maybe you help somebody, on their process of, like, moving out of a house. Like, maybe that first place is kind of risky, but it's not the high-risk using environment that they were in. It's still not healthy. That's a step in the right direction. That's harm reduction. We do it with smoking cessation all the time. That's harm reduction. You know.
Any other questions or comments?
Nope.
Okay.
All right, well, thank you.